Hello, I'm Darren. We have breaking news. More than 600,000 Americans have kidney failure. While the number of people with kidney failure is enormous, the number of people with its precursor, chronic kidney disease, is staggering. An estimated 31 million Americans, or about 10% of the US population. Diabetes and hypertension cause 2/3 of all cases of kidney disease. 1 out of every 3 Americans is at risk for kidney disease, and kidney disease is now among the top 10 causes of death in the United States. In addition, 9 out of 10 people with early to moderate kidney disease don't know they have it, putting their health in jeopardy. Are you at risk? For more information, contact urbankidneyalliance.org. The life you save may be yours.
What's going on? What's going on? Welcome to a midday show. Steve, the kidney nurse. Man, I just decided to come on and do this 10 important nuggets of access information. I mean, this is some information I found that I gave at the AAKP 2019 meeting, and so I wanted to share today. So if you're watching from YouTube, don't forget to subscribe, share, follow, like, because I'm going to be coming out with great tips that can make an impact. I'm serious, can make a serious impact on your care if you're on dialysis. So here we go. 10 important nuggets of access information. You're not going to get this from no other dialysis nurse because they're too busy trying to pass medication, do assessments, and the technicians, they got 3-4 patients. They ain't got time to sit down and go over any type of access information. So share this information. If you're watching now, you are definitely this is definitely beneficial for you. I mean, because once this show is over, it's over. You got to go back and watch it. But no one else is going to give you these 10 nuggets that you probably know or don't know about your access. All right, let's start with number 1. What is Still syndrome? How many people heard of Still syndrome? Also known as DASS, dialysis associated Still syndrome. And if you never heard of it, let me tell you what it's about. It's caused by excess arterial blood being shunted into the venous circulation through the anastomosis. So where you got the access cut at, or down here where we call it the anastomosis, where they make that surgical tie, arterial blood is being poured away. When they say shun it, it's being poured away and it's going into the venous circulation through the anastomosis. Now what happens, this leads to a reduction of blood flow to the extremity, the hand or the foot, wherever the access is. So basically, the creation of the access robs blood from the extremity distal to the access. Okay? Now, if Still syndrome is extreme, the surgeon may have to ban the access or tie it off to allow for more blood flow back to the distal extremity. That's why with some patients, when they have access surgery and they come to dialysis, They may want to put a glove on their hand because their hand may feel numb. That's the reason why, because blood is being shunted away or pulled away, and you're not getting enough blood flow down to your fingers. So when we put the glove on or go get you a say a glove with hot water or warm water, you can put your hand on it, you feel great. So, okay, let's see. Now, symptoms, let me tell you the symptoms associated with Steele syndrome. This is an access thing. One of the symptoms is pain, tingling and numbness, cold, cyanotic or blue fingers or nail beds. Okay. Nugget number 2, ways to distinguish the side from arterial on a horseshoe graph. Again, nugget 2, ways to distinguish the arterial side from the venous side on a horseshoe graph. So if you have a graph, these for people that have graphs, if you have a horseshoe graph, right, shaped like a horseshoe in your arm, and you go somewhere or a person come up who's going to stick you, ask you what side is your arterial, and you don't know, like you say, what side is your arterial on? You may say, I don't know, maybe this one or this one. Here's a way how you can distinguish that. To distinguish the arterial side from the venous side of a horseshoe graph, depress, push down midway, right? After this, I got to put up the education disclaimer. But you depress midpoint of the graph to partially obstruct the flow, to feel for the strongest thrill and listen for the strongest bruit. The strongest thrill or bruit is the arterial side. Also, you can insert both needles and secure with tape. Open up the cap of the fistula needle to bleed halfway down, but still able to see the pulsation of the blood in the needle. You depress midpoint of the graph, the needle with the strongest flashback is the arterial side. And then 3, you can ask your surgeon what side is the arterial side, or get a copy of your operative report, and that should show you or explain the blood flow direction. Now, before I move on, I just want to say this to you guys. I'm definitely knowledgeable in this, but let me just give you education disclaimer. The information broadcast on this show and any show on Urban Health Outreach Media is provided for educational and informational purposes only, and is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. Now, with that being said, let's move on to nugget 3. Why is it important to determine which side is the arterial and which side is the venous? That's very important, guys. If the needles are connected to the wrong bloodline, recirculation will happen, or recirculation will prevent the clearance to deliver adequate treatment. So if the lines are connected backwards, you can have something called recirculation, and you won't get a good treatment. So you got people, that's what I'm saying. If you know this, you can make sure that the technician and the nurse are connecting the bloodlines, like the arterial to the arterial and venous to the venous. You got to make sure that connection is right, because if they don't know, or they forget, or they're not paying attention. And if you're not watching what they're doing, who's going to be at risk, or who's going to, affect the most? The patient. So number 4, my fourth nugget. What observations should be made by the dialysis caregiver when assessing the internal access, meaning graft, fistula, pre and post treatment? Guys, this is very important. Share this. Man, I swear, people who are not on here watching, man, they missing out. I just hope that people come back and get these nuggets. But for the people watching, if you got access, or your parents or your loved one got an access, man, these nuggets are going to be great for you to just see and just put it in place and see. But what observation should be made by the dialysis caregiver, meaning the tech or the nurse, when they're looking at your access, meaning the fistula or graft, before you go on dialysis, and then after you come off dialysis? What should these people be looking for? You need to know this so you can make sure your access is not going to be messed up or infected. So an internal access is a graft or fistula. All right. The internal access should be checked pre and post treatment for signs and symptoms of 1, bleeding, 2, swelling, bruising, redness, drainage, pus, and for changes in thrill or bruit. Also, be aware that post-treatment hypotension can cause a decrease or compromise blood flow to an internal access, causing access to clot. Let me repeat this, and this is very, very important, especially if you're one that suffers with hypotension post-dialysis. And when I say hypotension, I'm talking about pressures 100 and below, 100 over 70, 90 over 60, 85 over 56, something like that. You can be at risk for clotting of your fistula or graft because your heart is not pumping out. So that reduced blood flow getting to that access is going to be decreased. So please be mindful of your blood pressure post-dialysis and at home as well. Number 5 nugget. How can the dialysis team help you protect the life of your access? The dialysis team can help prolong the life of an access by 1, using site rotation. This is important. A lot of patients don't know this, about site rotation. Some people want the nurse or the technician to cannulate them or stick the needle in the same spot each treatment, because each time you do that, it lessens the pain. But you got to rotate that site. You got to move 2 inches or 2 finger breadths apart from the last site that you stuck, all right, to maintain the integrity of your graft. That's why you see a lot of people with their access, 3, 4 accesses. You got to maintain it, guys. So 1, using site rotation, which prevents the formation of aneurysms and scar tissue as well, and allows the site sufficient time to heal. Who's going to sit down and tell you this information other than Steve, the kidney nurse? I mean, you may have some people to do that. I'm not knocking that There's not education out there telling you this stuff, but at 1 o'clock in the afternoon, two, thoroughly assessing the access before each treatment. What I mean by that, before they stick those needles in your arm, you make sure they look, listen, and feel your access. Look at it. You want to look at the arm. Make sure you don't see any redness, any swelling, any crust, any pus, any discharge. Listen. You want them to put the stethoscope on and listen, okay? Listen for that thrill, that bruit, right? You want to listen, right? Listen to the bruit. And then you want to feel for the thrill. That's what you want that caregiver to do, that dialysis technician or nurse. You want them to do that. That's what we mean by thoroughly assessing the access before each treatment. All right. 3, using good aseptic, you can't do sterile, but good aseptic clean technique during all cannulation procedures. Meaning when they wipe your arm with the alcohol or betadine and allowing it to dry for 5 minutes, right? Not taking the cap off the needle and walking around the freaking dialysis clinic with the cap off the needle. I wish I had one of my needles with me. I don't. I apologize, but it's a cap to come on the needle. That needle is sterile before that cap comes off, or it's sterile in that package. Once you break it out of that package, it's no longer sterile. But you don't want these guys walking around with the needle with the cap off, because you got germs in the air. Okay. Excuse me. All right, there we go. So you want to make sure before they put those needles in, they wipe your arm down. They got on clean gloves. And when they take that cap off, they're sticking it in right then and there. And they're not taking the needle out and laying it down if they have issues, and then come back and try to put that same needle in. No, don't let them keep going in the same digging around. That's how they mess up your access. All right. Never cannulate. I repeat, guys, if you got an affected area, let me see if I got that picture. I posted a picture on social media of an access. If you've been following, go to Steve, the kidney nurse page on Facebook, and you'll see an access that's infected. But don't allow these guys to stick a needle near an access that's infected, because that's going to cause you to be septic. Once that germ gets in your bloodstream, it's a done deal. It's a wrap. And next thing you know, halfway doing treatment, you're shivering, like, what the hell is going on? You're shivering and shaking, teeth chattering. We drawing blood cultures. Next thing you know, I'm calling the nephrologist. Oh, so-and-so got a temp of 100.3. They shivering, they shaking. What you want me to do, doc? Give them a gram of vancomycin and 80 of gin. And so now the nurse is coming back to your chair. You in there shivering. Tech's got 3, 4, 5 lab coats over you. How many know what I'm talking about? You're shivering, and now it's maybe 30, 40 minutes before treatment. Now they're giving you antibiotics. You just ready to go home, right? You ready to go home. This is nothing you did. Again, you got to watch these guys when they sticking that needle in you, because even that can give you an infection. If they stick near an area that is dirty or that is not clean, they can introduce those microbes into your bloodstream, which can cause you to be septic. But a lot of warriors don't know this. They think it might be from something else, the flu. That's why you got to be armed with this information. 5, thorough patient teaching. Again, thorough patient teaching can help you protect the life of your access. Thorough patient teaching. 6, a lot of warriors don't know this. If you use clamps at a clinic, or they put these white clamps on you to stop the bleeding because you can't hold because your fingers are cramping, or you just, for a lack of a better term, too lazy to hold your sites, right? They put 2 clamps on it. Stop that. No clamps on your access site. Only use 1 clamp at a time. Not removing the second needle until the first needle has stopped. How many people pull both needles because you was ready to just get out of there, and when you pull both needles, you bled all over the place? Stop doing that, guys. Just take your time, 1 site at a time. Don't let them put 2 clamps on you and push you to the corner and then put a new chair right there. That's that factory worker mentality, treating you like a number, like you on the Amazon assembly line. Those days are over with. Don't let them put you in the chair and push you to the corner until you start bleeding, and they don't come back until 45 minutes later, and you done been stopped 20 minutes later. Now, making sure to assess the clamp needle site at least every 10 minutes. Again, only use 1 clamp at a time, not removing the second needle until the first has stopped. Making sure to assess the clamp needle site has stopped at least every 10 minutes. You got to look at this, because you think it's stopped, they bandage it up, and you go to your car. Next thing you know, you're driving home, Miss Daisy, and you feel something warm in your sleeve. And you're like, oh my God, why is my arm so warm? Next thing you know, you're bleeding all in your car. You turn around, you go back to the clinic, you slam on the brakes, you rush in, go into the clinic, and you take off your jacket, and you got all this blood that's like gelatin, it clotted up, and they're wiping, they're trying to clean it with the peroxide, and everything looks all bloody, and then when they take the tape off, it stops bleeding. You want to prevent this before you leave the clinic, okay? Make sure everything is taped, gauze, secure, and you waiting around 5 minutes before you bounce to prevent that. And then when you come back, they may take their time getting to you because they're putting on somebody else. Or they may have the same gloves on that they used that they were just doing. They're not clean. You see how stuff like that can get kind of lost in the sauce? So that's why you have to be mindful of what's going on with your treatment and everything that, how Wu-Tang Clan say, Cream, Cash moves everything around me. So look, Number 6, this is for people who want to know. And I saw somebody ask this in one of the groups. What is a buttonhole technique? What is the buttonhole technique? Come on, get some more people on here, guys, because I don't know where else people are going to get this information. Share this video wherever you're watching. Thank you to the YouTube people if you're watching on YouTube. If you're watching on Steve, the Kidney Nurse page, thank you guys. But share this, man. Let other warriors see this. We're going to talk about the 6 important nugget. What is the buttonhole technique? Right after this important, and I mean important, PSA. Okay, guys, I'm back. Before I move on to that important nugget number 6, I just want to thank Stephanie Smith, Michael Barrett, Hilda Moore, and Fanny. Hey, Fanny, my messenger is not working, so that's why I haven't been able to reach out to you. Thank you, Fanny. And Fanny's from Zambia. We got Zambia in the house over in East Africa, so we're trying to reach all kidney warriors. Zambia, UK, Asian, Pacific. Guys, we need all the support to bring kidney awareness to the forefront. Let people know what kidney warriors are dealing with on a daily basis. So thank you, Fanny, for watching from Zambia. What happened was yesterday I did a blast text to try to boost my YouTube page, Steve the Kidney Nurse. And please go to Steve the Kidney Nurse YouTube page, show support, subscribe. But I sent out about 100 messages. Now I can't send nobody a message in Messenger. So what I think they've done is block me in Messenger for a while or prevented me from using that option in Messenger. So if you haven't heard from me in 2 days, that's why. So let's talk about number 6. What is the buttonhole technique? The buttonhole technique is used for the cannulation of fistula to the same site at the same angle for each stick. So when you use a buttonhole, what happens is a scab forms up. Normally, a nurse or a technician that's really good at needle cannulation establish what they call a track into that access. And that's the same site, at the same place, at the same angle. So if you're going at a 30-degree angle, you got to go at that 30-degree angle all the time. Going at 45, whatever angle you're going in when you stick in that needle. Say this the needle. When you go in there, you got to go at the same site, same angle. A buttonhole is made, now check this out, by repeatedly cannulating or sticking into the same puncture site each time. After a track of scar tissue is established, a blunt needle is used to cannulate the access. So it's not sharp anymore. They got these special needles. It's a blunt needle. And some of them come with this piece. They got this pick on the end. So you can use that pick to pick off the scab that forms over that hole. And, you know, the advantages of using the buttonhole technique include fewer infiltrations and infections, decreased blood loss post-treatment, fewer missed attempts at cannulation, less painful for patients, decreased amount of scar tissue, less damage to surrounding tissues, increased longevity of the native arterial venous fistula. So it increased the longevity, increased confidence for self-cannulation. So if you wanted to stick yourself, this will give you confidence that you can do it because you go into the same site at the same angle each time. It's not fumbling around and all that. Pick off the scab, and you put peroxide or saline on the gauze and soak the scab to make it easier to pick off. Once you pick that off, you just go boom, boom. If I ever get on dialysis, that's what I'm doing. But first, I'm not going with the access. Let me just tell you that. Let me put on the brakes. If I ever have to undergo dialysis, Steve, the kidney nurse, first, Steve, the kidney nurse is going to assess the situation first, meaning my age at the time, my quality of life, and conservative treatment. That's the first thing to do before I even touch a machine, whether it's PD or hemo. I'm going to do some assessments of my life before we determine what the next step is. And then from that assessment determines what happens. So I have kids, grandkids. So, my age is a factor. Also, my health was going on at that time of the diagnosis and what the percentage of the GFR. A lot of that comes into play. So, but if it ever got down to the nitty gritty and I did go on dialysis and I had to go on hemo, it would be home hemo. And if I had to get a fistula or access, it would definitely be a fistula. And I would use this product right here by Dr. Ted Singh, arm wellness device. And what this do, it helps you build your veins up before you even get surgery. So you can have a successful surgery and a successful fistula. These things right here go for about $99 on Amazon. However, Dr. Singh, that's why it's important to watch Steve, the kidney nurse. All right. Dr. Singh has blessed me. Dr. Singh has blessed your boy, right, with 2 of these. And we're just trying to come up with a way in how we can auction off or market off both of these, right, for 2 warriors who are about to get maybe access surgery in the near future, right? Because what this does, it enhances your veins so you can have a better working longevity AV fistula or arm wellness device. And so in the back, you can see for yourself how this works, the clinical advantages, vein wellness, vein enhancement, vein stimulation, vein strengthening, vein augmentation, right? We got 2 of these boys. So we that's what I'm saying. Christmas is coming around the corner. So we got to do something fast on having maybe somebody write a 200-word essay on why you think you need this arm wellness device. I don't know, but we got to do something fast, and I got to get with my advisors to see what we can do to auction off or give away 2 of these. And see, he even blessed me with one to use for myself to show you that it works, and it works. So that's what I would do. I would build my veins up, and I would use or go with the buttonhole technique, and I will find the best, I mean the best and the brightest access surgeon. You need to talk to an access surgeon, vascular surgeons who at least done over 3,000, 4,000 of these. You want somebody who knows their work. Sometimes these people, your nephrologist sends you the people that they know, and those vascular surgeons can be, for a lack of better term, shitty. I'm sorry. This is Steve, the kidney nurse. You either love him, like him, or you love him, or you hate him. But I got to tell you like it is, because it's no damn way kidney warriors should be walking around here with 4 or 5 accesses, right? Because my thing is this: if you did one and didn't work, and you did the other one and that worked, what did you do different for the other one to work and not the first one, right? So let's cut through the bull crap, do a vein mapping, tell me, what are the larger veins I need to be using and what I need to do to augmentate that vein, stimulate it, or enhance it to have a successful vascular surgery where only have one access. Because if they're doing vein mapping, they know before they go under the knife if your veins are small or not. So don't fall for the trickery or the hocus pocus, because when they mess up your access, or if they do an access and if it doesn't work, you don't get your money back. It's to the next arm or down to the next vein. And if that doesn't work, they still get paid and you don't get your money back. So it's not 30-day money back guarantee. That doesn't work with access surgery. So you want to make sure if you're starting dialysis that you're armed and prepared with 10 important nuggets of access information. So now what I was saying, advantage of using a buttonhole technique includes fewer infiltrations and infections, decreased blood loss post-treatment, fewer missed attempts at cannulations, less painful for patients, decreased amount of scar tissue, less damage to surrounding tissues, increased longevity. That's what you want. Longevity of the native. That means your own arterial venous fistula, increased confidence for self-cannulation. What you want to do it yourself. So if you mess yourself up, you did it instead of someone else who didn't know what they were doing. And last but not least, decreased amount of accidental needle sticks because of using a blunt needle. The needle is blunt. It's not sharp. I can't tell you how many times your boy stuck yourself right here when I was getting ready to put a patient on and I was being haphazard and reckless, and I accidentally stuck myself with a needle that I had poured out of a patient because I didn't get the access. And did I look in the records to see if the person was HIV positive? Absolutely. I'm not going to lie. Did your boy go down to Concentra for testing. I sure did. However, your boy did not take the antiviral medication. That makes you sick as a dog. And I'm not saying that for anyone else not to do if they get stuck with a needle. I'm just saying what I did. The person wasn't positive, but that's what the healthcare workers do. Even when patients start dialysis, they go through your charts to see if you have HIV. That's right out the back. And I'm just going to cut it right to the point and tell you, any patient that starts dialysis, you better know that they're looking through your records, because they send your records to the unit before you get there to determine if we're going to accept you or not. So if I'm the charge nurse, they say, we got a new patient coming tomorrow. So say, like, for instance, I don't mean to be putting her business, but she already put it out there. Brooklyn Weave, she asked for prayer because she starts outpatient dialysis today in Georgia. And I told her, call me so I can be right there. You give permission to let me listen in, or do a what you call it on the what's that? FaceTime, right? I could be right there with you and see if they're going over everything, and if you got any questions about it, and make sure that she understands everything that they're saying. I'm willing to do that for her because I know, right, the anxiety a lot of patients feel on the first day of outpatient treatment. I know so much that Steve, the kidney nurse, wrote a book of how to survive outpatient hemodialysis, a guide for patients with kidney failure. This book should be out by the first of the year, so please hold on if you're dealing with stage 4 or 5 and it looks like you're going that way to dialysis. Number 7 of this nuggets. What insertion angle should be used for cannulation? Again, what insertion angle should be used for cannulation? Meaning, what angle should the technician or nurse use when they get ready to put that needle in your arm? So cannulation should be performed with the fistula needle with the bevel up. Man, I swear I need to go get that needle. But anyway, if you see the needle, you know how the bevel is up, facing up that way. Say this is the needle, the bevel front of the needle, and that's the sharp point right there. It should be faced up, right, with the bevel up. The fistula needle should not be rotated or flipped. When they get that needle in your arm, they should not flip it, because that can tear your access. The sharp point of that needle. I need to go get that, guys. Hold on for 1 second. I'll be right back.
Hello, I'm Darren. We have breaking news. More than 600,000 Americans have kidney failure. While the number of people with kidney failure is enormous, the number of people with its precursor, chronic kidney disease, is staggering. An estimated 31 million Americans, or about 10% of the US population. Diabetes and hypertension cause 2/3 of all cases of kidney disease. 1 out of every 3 Americans is at risk for kidney disease, and kidney disease is now among the top 10 causes of death in the United States. In addition, 9 out of 10 people with early to moderate kidney disease don't know they have it, putting their health in jeopardy. Are you at risk? For more information, contact urbankidneyalliance.org. The life you save may be yours.
Okay, guys, this is important. Now, what I was saying about the insertion site and the needle, if you undergo hemodialysis and you have a fistula or a graft, let me see something. Here we go. You see that? That side should be up. When they're sticking the needle, that's what I mean by the bevel up, right there, pointing up. And you see that little hole in the center, right? That eye, that's why they don't have to flip the needle anymore. And you see how sharp this is right up here? If this is in your arm and they flipping the needle, right? That can tear. You see how the diameter of this needle, how big you think your veins are, right? So if they flipping this needle right here where it's sharp, this is the part right here that could damage your access. That part right there, and it's sharp. So, and see the needle, this is a back eye. That back eye that's in that needle to alleviate flow problems, right? And the need for flipping. And I'm sorry, and to alleviate the need for flipping. That's why I said, don't let them tell you, let me flip the needle if they having issues with your access, because that back eye right there, right, alleviates that from happening. So more than likely, if they got to be adjusting the needle, they stuck it the wrong way or they having issues. Don't let them put the blame on your access. Generally, fistula needles are inserted into an AV graft at a 45-degree angle and into an AV fistula at a 20 to 30-degree angle. However, the angle is really dependent on the depth of the access. So again, if your access is on the top of the surface, right? If it's on the top of the surface, this is the 20 to 30 degree that they're talking about. That's 20 to 30 degree how I'm holding the needle. This is 45 degree, especially if you're going into a graft. About 45 degree, 20 to 30. What a lot of technicians and nurses do, they go too deep on your access and they go right through it, thus causing infiltration, the blood to seep out in that hole into the surrounding tissue, causing swelling. So, yeah, and so if you have a person that is a kind of heavy set in their arms and they got a lot of fat in their arms, the access may be deep. And in that case, this needle right here is a 1 inch, 1 1/4, meaning the length of the needle is 1 1/4 length. But the yeah, 1 1/4. What most needles are 1 inch, but this is 1 1/4. Oh, and one more thing. Make sure when they if you at dialysis and when they put the needle in and after they get the blood, make sure sometime they leave the cap off or leave it loose and they don't clamp this back right here. They forget to clamp that. And when they put the needle in, the blood spills out and it's a mess. It looks like carry. It's a bloody mess. So make sure when they put this needle in that this is clamped. If it has one of these clamps on it and they don't take this cap off inadvertently and leave it off, okay? Number 8. This is a good nugget as well. Some important guidelines for needle placement, right? When a nurse or technician is evaluating your arm, if they cannot feel the thrill, have them listen for the bruit. If neither is present, they should not cannulate the access. And what I mean by that, they may say, oh, I can feel it, but I can't really feel it. right? And then the next thing you know, they put the needle in and they digging around, right? And then they see it and black blood comes out. Black blood. That means your access is clotted. Well, you could have prevented that and putting you through that damn trauma with the needle. All you had to do is listen. If you didn't feel the thrill, you listen for the bruit. But if you're too lazy to do it, they're putting your access at risk. So make sure that they do both. They listen and they feel before they put that needle in. Staff should stay 1.5, right? 1.5 to 2 inches away from your anastomosis site, right? The anastomosis site is where the juncture where they do the surgery. It's either down here or up here, somewhere like that, or down here in the wrist, depending on what type of fistula they put in. But the staff should stay away from that area. Don't have them stick there, because I experienced, man, a horrible situation back in the 80s. I put this old lady, she was like about 85 years old, man. I messed up her access. I was a technician, dialysis tech, and I'm not taking away from techs, but I didn't know any better. And the surgeon told me to go there. A doctor told me to stick there. So stay away from anastomosis. Needle tips should be at least 1.5 to 2 inches apart. Needles placed too close together cause recirculation and inadequate dialysis treatment. Let me repeat that. Needle tips should be at least 1.5 to 2 inches apart. Needles placed too close together cause recirculation and inadequate dialysis treatment. Do not select an aneurysmal or pseudoaneurysmal area. What I mean by that is do not stick in a site that got those lumps. Those are aneurysms. Do not continue to go in those aneurysms. You're making it worse. Tender areas should not be selected for needle placement. Tender areas should not be selected for needle placement. Sites that appear infected, and what I mean by infected, these are the classic signs of an infected site: redness, drainage, tenderness, or swelling should not be selected for cannulation. I repeat, sites that appear infected, and what I mean by infected, redness, drainage, tenderness, or swelling should not be selected or used for cannulation. If a needle penetrates an area of access infection, the needle can carry the infection to the bloodstream, causing septicemia or infection. Number 9, what direction should your needles be placed for optimal dialysis? The nugget, number 9, what direction should your needles be placed for optimum dialysis? The arterial needle goes with or against the flow. Okay? Let me repeat that. The arterial needle can go with or against the flow. However, the venous needle, this is critical, the venous needle must be placed in the direction of the blood flow. Again, the venous needle must be placed in the direction of the flow of blood. And last but not least, nugget number 10. What is an infiltration and how is it treated? Yes, the mother lode of all, an infiltration. How many warriors experienced that? Large hematoma, technician or nurse digging into your arm and you're telling them that's not it, but they insist they are there. And soon as they cut on the blood pump, boom, your arm blows up. Cut the pump off, stop, ouch, ouch. How many of you experienced that? Technician running back over to the machine because they turned you up all the way and left the machine. And you feeling this pain, you screaming at the top of your lungs. Yes. What is an infiltration and how is it treated? An infiltration is fluid seepage into the surrounding tissues, resulting in pain and swelling. That's the bottom line. The blood going through that hole that they went through with this sharp needle, right? It can happen. Somebody, see, this is what we talk about, putting your life, and in this aspect, your access, your life in someone else's hands that has little or no intentions on being the best caregiver they can be. They're just there for the money. As Bones and Bone Thugs and Harmony say, for the love of money. That's what it's about. So the better prepared you are, you know, the best chances you have on having a great treatment. So, again, an infiltration is fluid seepage, your blood, into the surrounding tissue, resulting in pain and swelling. Infiltrations are treated with intermittent ice for 24 hours, followed by intermittent heat and ice as needed. A new venous needle should be placed, this is important, above, not below, above the infiltration site. For an arterial infiltration, the needle may be placed either above or below the infiltration site. And in fact, if it's placed below the infiltration site of an arterial infiltration, it may even draw some of that blood out of that tissue and reduce that hematoma. So again, if they infiltrate you in your venous and they want to pour the needle and re-stick you, it got to go above the venous infiltration, not below it, because if they stick you below that infiltration, it can make matters worse. Trust me. Not all nurses, not all dialysis nurses and dialysis technicians are created equal. I tell you. Let me check my comments out and call it a day. Brother Jared Brown, thank you, man, for watching. Oh, absolutely. Absolutely. Yes, buttonhole technique sounds like it can increase. Absolutely, man. And that's what we got to get out to warriors and let them know that they have choices, options. But if they don't know about the buttonhole, right? How are they going to ask that question? Absolutely, Jared. All right, that's my sister in Thomasville, Sister Felicia Morris, and my PR spokesperson. She don't know that yet, but this is my future PR person. I'd like to introduce her to you. Felicia Morris. It's going to be my marketing and PR person. Yeah, Jared, you can't get this information. So share this information, even though it's one person. I know it's 2:28 in the evening, but where else are you going to get this information at 2:28 in the evening, right? Especially from a certified nurse educator. Yes, every patient must have this. Knowledge is key. It's critical now more than ever, Jared, because of the increase of patients being diagnosed right now. Right now, there's someone being diagnosed with kidney disease that's starting dialysis. Right now, as I have this broadcast, right now, they're at the clinic being read to informed consent for treatment for dialysis. And that's a shame, and that's what we want to decrease. And if it happens, we want to arm you with education, so when they're coming at you with needles like this, you know the angle that they should go in. You know they should be rotating your site, not going in the same area. You know they shouldn't be taking off the cap before they put, clean your arm. No. And that's probably more than half of the battle right there. The rest is the battle with the mind. Once you get the education down, this is the next thing. Or this may be first, and then the education. Either way is interchangeable. So, Ziggy So Real, thank you, man. That's what I'm trying to do, be real. Yes, please, brother, sister, share this. Share this information in any group you can. I'm going to be on here, try to be on here every day with nuggets of different information that can impact or have an impact on your life. And I'm praying that it can. So with that being said, God bless you guys. I hope you enjoyed 10 important nuggets of access information. And I wanted to only do 30 minutes, but like I tell patients at the dialysis clinic when I do their assessments, I just can't come and just listen to you like a robot. I got to ask you questions, see if anything is going on. And if you tell me, then we got to investigate it, right? Well, it's the same with the information. I just want to break it down, let you know what's going on. And it's something, if you didn't understand it, hopefully before this broadcast is over, you will understand it and see how it applies to your treatment or to your situation as a kidney warrior, regardless of where you're at, whether you're in Zambia, whether you're in United Kingdom, whether you're in South Africa, Cameroon, India, Pakistan, China, United Emirates, Bulgaria, Russia. Regardless where you're at, what we want to do, or what Steve, the kidney nurse, want to do in conjunction and in collaboration with AAKP, Transplant Journey, Mental Health and Me, and the rest of Urban Health Outreach Media, is get this information out there as fast as we can and as quick as we can to the masses that need this information. So with that being said, thank you guys for watching. God bless you, and I see you on the other side. May peace be upon you. God bless. Thanks.
Yeah. Uh-huh. Yeah. Yeah.